Assalamu alaikum. Good morning, everyone. First, I would like to thank the guys in saaeda company, the distributors of Samsung ultrasound systems, for allowing me or giving me this opportunity to meet with this amazing group of radiologists in the amazing city of Sulaymaniyah. My name is Ahmed D. Abdulwahab. I'm a clinical and interventional radiologist working currently in Razgari Teaching Hospital in Erbil. I'm a trainer at the Kurdistani Board of Radiology. First, let me say, a while ago we had some residents from here working with us in Erbil, and they were extremely amazing, showed some excellent level of commitment and scientific knowledge. So this is a very good indicator of the level of radiology in this great city. So, regarding liver sonography, it's a huge topic to be presented in a limited amount of time. I hope I can finish this before you fall asleep. I will try my best. Okay. So, first, before I forget, I have a YouTube channel. This talk, as well as many other talks, are available there. And if you like, you can just subscribe, push this button, the red button, subscribe, write my name, and you will see the lectures as they being posted. Today we are going to cover the following topics. First, the normal liver and the Doppler of hepatic vessels, including the portal veins, of course, diffuse liver disease patterns, portal hypertension, and focal liver masses. Regarding the normal liver anatomy, first, everyone knows we have to check first for the, let's say, obvious things that are the size, the shape, the echogenicity, and the ecotexture. What I want to emphasize here is that the echogenicity and ecotexture are two different things. Echogenicity means the level of brightness of the liver. Is it white? Is it black? Is it gray? What is the level? Is it normal or is it abnormal? While the ecotexture is the smoothness of the liver. Is it rough? Is it smooth? And in what pattern it is? And we will talk a lot about it in the following slides. In order to make this evaluation accurate, we need a good technique. That means we have a smooth TGC curve, and in every patient, we should try our best to visualize the diaphragm. The diaphragm should be visualized, like for example, in this case, I hope you can see. Is it here? Like here, it's the diaphragm is visible completely. Okay, you need to see as much cephalic as possible of the liver. Of course, this is not always that easy, especially in obese patients and markedly diffuse fatty liver. This will be difficult, but it is very important to see the diaphragm, see the vessels lumen, and you should clear all margins. What do we mean by that? First, regarding the vessels lumen, you can see there are two types of vessels here. The one that's echogenic walls, you can see the echogenic walls, and the ones that have practically no wall. And in general, there are some exceptions, but in general, the ones that have no wall are hepatic veins, while the ones that have echogenic walls are the portal veins and their accompanying hepatic artery and bile duct system. Regarding to clear all margins, that means we need to see all around the liver, all the edges of the liver, like everywhere, okay? Not allowing everything to stay out of the field. For example, here, you can see, this is the okay, thank you. This is the previous image, and this is another image. You can see here, although the diaphragm here is obvious, as we can see here. I'm not a very good painter, but that's my best. The curve is not smooth. There is some shadowing or something here. You can see it, it's different. That's just an artifact. It's not a disease. And if you change the probe angle and change the position of the patient, try other maneuvers like deep inspiration, this can be seen as clearly as this one here. Okay, so you need to have a very smooth and obvious visualization of the liver. Regarding to clear, always clear at least 2 to 3 centimeter beyond the edge of the liver. In fact, it's not the liver, it's like every organ. You need to see at least 2 to 3 centimeter outside the edge. Why is that? Sometimes there are exophytic masses that are hanging from the organ, hanging from the liver. So if you try as much as possible to clear the margin, you will not be able to separate the mass from the liver. For example, in this case, you can see this is the liver here and here, okay? And you can see that this part, this one here, cannot be clearly separated from this thing, okay? There is some exophytic lesion, maybe 5-6 centimeter, hanging from the liver, and it appears like connected to the liver, okay? This was a hepatocellular carcinoma, a hepatoma, okay? And it was an exophytic tumor, just hanging from the edge of the liver. If we did not try as much as possible to, if we did not try as much as possible to clear the margin of the liver, we would thought that this is something in the mesentery, in the stomach, in the pancreas, whatever. So just trying to clear the margins of the liver will be extremely helpful in catching the exophytic masses, the masses that are hanging from the liver. If you think this is like a rare case, there is another case, for example, here. You can see this is the liver here, and this is the kidney, okay? And there is something hanging from the edge of the liver, okay? This mass. Again, it was a hepatocellular carcinoma, a hepatoma. You should always try to clear the margin of the liver to be sure that there is nothing hanging from the liver, okay? Regarding the parenchymal organ echogenicities, every organ in the abdomen has its own echogenic pattern, okay? We should be familiar with the normal echogenicity so that we can know the abnormal echogenicity. The rule here is that the renal medulla is the most hypoechoic part of the abdominal organs. For example, you can see this is the medullary pyramids. They are very hypoechoic compared to the rest of the image. So the renal medulla is the most hypoechoic. The cortex is slightly more hyperechoic, and the renal cortex and the liver can be either the same, or the liver might be slightly brighter. Before we thought that this was not true, but at the time being, sorry, whose mobile is that? Anyway, not mine. Sorry for the interruption. Anyway, but now we know that in certain patients, especially in young and thin patients, the liver and the kidney can be the same echogenicity. It's not necessarily due to fatty infiltration. Okay, liver is almost the same as the pancreas, and the pancreas is less than the renal sinus and the retroperitoneal fat. The retroperitoneal fat and the fat in the renal sinus are the most hyperechoic structures. Okay, usually we say the liver should be less echogenic than the spleen. This is true, but it is difficult, because it's not that easy to visualize the liver and the spleen in the same slide and to judge which one is more or less hyperechoic than the other. But in some cases, for example, in this case, this is the spleen, okay? And you can see there are two different echogenicities. This one is hypo and this one is hyper, okay? And what's going on here? Is the spleen have two different echogenicities? Another thing to notice here is that this part has some vessels in it, more than this. This part has no vessels, okay? What happens here is that this is the left lobe of the liver, going all the way to the left side, hugging the spleen. And you can see both of them in one image. If you pay attention to that, you can avoid making some terrible mistake of, for example, diagnosing a perisplenic hematoma. Someone can say this is a perisplenic hematoma. It's not. It's just the liver extending all the way to the left side of the spleen. Again, we can see here, this is the liver and this is the pancreas. They are almost the same echogenicity, as we said previously. Now, regarding the vessels of the normal liver, sonographically, the vessels visible within the parenchyma of the liver are two types: the hepatic veins and the portal veins. The hepatic arteries and the bile ducts normally are not visible. You cannot see them, okay? Unless they are dilated due to some disease process, okay? Where do we see all of them? The biliary duct, the hepatic artery, and the portal vein, we see them in the porta hepatis. That's it. In the liver, you don't see the hepatic arteries or the normally non-dilated biliary tree, okay? The hepatic veins, as we said, they usually have no perceptible wall, while the portal veins have perceptible wall. And why is that? This is because what you see, the echogenic wall is not only the portal vein, it's the portal triad. There are arteries and biliary ducts accompanying the vein in the surrounding, giving it increased echogenicity, okay? But you don't see them because they're so small. So, the liver has 4 tubular systems, let's say. These are the hepatic veins, the portal veins, the hepatic artery, and the biliary tree. There are 4 systems. 3 of them together joins at the porta hepatis, that's the hepatic artery, the portal vein, and the common bile duct, here and here and here, okay? And the 4th system, that's the hepatic vein, are separate. The 3 that joins in the porta hepatis, all of them going to the liver, while the hepatic venous system is going out of the liver. It brings blood to the heart, okay? This is important we'll know why in the next slides. So, regarding the portal veins, as we said, they have echogenic and bright walls, and they are useful for evaluation of the liver parenchymal echogenicity. The main portal vein enters through the porta hepatis. The largest portal veins divide in the middle of the liver, okay? So, the main portal vein enters through the porta hepatis, and the largest portal veins divide in the middle of the liver. The portal veins are more horizontally oriented in the liver. It's like horizontal pattern. They are within the loops and within the segments, and they flow into the liver. As we said, the reason for the bright walls of the portal vein are the portal triad flowing with the portal branches, okay? In addition, there are other things like the Gleason capsule and the lymphatics and nerves and the connective tissue surrounding the portal veins. All of these together gives the portal venous branches their echogenic walls. While the hepatic veins, they have imperceptible margin. They enlarge toward the IVC. As you go to the more cranially to the IVC, they become larger, like you see here. For example, it's lower and then it's larger. Okay, they are more vertically oriented, and they have umbrella configuration. They meet at the top, at the IVC. Sorry. The hepatic veins, this is very important. They are between the lobes and the segments. Okay, they are used as dividers, anatomic dividers, and they flow out of the liver. For example, here, this is the umbrella that we talked about. The spokes of the umbrella, this one and this one, are the hepatic veins meeting at the apex of the liver at the IVC. Okay, this is the IVC here. This is the right hepatic vein. The right hepatic vein is this one. The middle hepatic vein is this one. Okay, as you go, this cut is at this level. While if you go more caudally, the hepatic veins will become more, like here, more vertically oriented. Okay, and you can see them as rounded dots. This is the portal vein here. Okay, and the rounded dots are the hepatic veins going vertically into the liver. There are some exceptions to the rule that the portal veins have echogenic walls and the hepatic veins have no walls. For example, you see here, this is the portal vein, okay? And this is a branch of the portal vein that have no perceptible wall. And why is that? It's just an artifact. This is going parallel to the beam, the ultrasound beam. And the parallel means the worst angle you can ever have in ultrasound, okay? So this has an echogenic wall here because it's perpendicular, while this is parallel to the beam. That's why it has no perceptible wall. It's not abnormal, it's just if you change the angle of the probe, if you move the patient, you will see the wall, okay? Again here, this is the hepatic vein, okay? And it has wall here, it has echogenic wall. And why is that? Because it's perpendicular, not parallel. So there are some exceptions, but the general rule is hepatic veins have no walls, portal veins have walls. Now we should know some anatomic landmarks to know where are we in the liver. In the upper cuts of the liver, there is a very characteristic appearance of the IVC, the left, middle, and right hepatic veins joining together in this umbrella configuration. In the middle of the liver, you can see this is the portal vein bifurcating, okay? And this is the IVC. These are very important landmarks, while usually the left portal vein is higher than the right portal vein, just slightly higher, not much, okay? And in the lower, in the more caudal part of the liver, you see usually this echogenic part is the falciform ligament. The falciform ligament has the ligamentum teres at its end. And ligamentum teres means literally the round ligament. There are many round ligaments in the body. In the liver, there is the ligamentum teres that is in the lower aspect of the falciform ligament. It just represents the obliterated fetal remnant of the umbilical vein. In the fissure of the ligamentum teres, there is umbilical vein going to the left branch of the portal vein in the fetus. When the baby is born, there is no need for this vein. It gets obliterated and becomes the ligamentum teres. It may recanalize in portal hypertension. So it's not always closed. There are some conditions that recanalize the umbilical vein. It should not be mistaken for a mass or calcification. And it is an anatomical divider. It divides the left lobe. We will talk about it in a minute. For example, you can see here in the transverse section, there is an echogenic structure here. This is the ligamentum teres. It should not be mistaken for a calcification. You can see some acoustic shadowing posterior to it. If you just change the angle, this will disappear, while if it's a calcification, the acoustic shadowing will stay no matter what angle you come from. Okay? In the sagittal images, you can see this is the left portal vein, and this is the ligamentum teres joining the left portal vein. Ligamentum venosum, it's the obliterated fetal remnant of the ductus venosus. This is a vein in the embryo that is bringing blood out of the liver. Blood comes into the liver, there is no need for it to stay there, and it goes out of the liver, okay? It lies within a fissure of the ligamentum venosum. It does not recanalize in adults. There is no recanalization of the ligamentum venosum. Nothing that causes its recanalization. It separates the left lobe from the caudate lobe. For example, you can see here, this is the IVC, okay? This is the caudate lobe, and there is some echogenic plane or band. This is the ligamentum venosum, okay? And in the transverse sections, you can see also this is the ligamentum venosum, and you can notice it's aligned in both planes, so indicating it's a plane. It's not just a band, okay? It's a whole septum. Now, regarding the caudate lobe, caudate means tail. This, for example, in this puppy, you can see this is the tail. It's, in fact, it's not in the liver. It's cranial in position. It's not caudal, but it looks like a tail. Okay, so it is functionally autonomous. It works by its own. It takes blood supply from right and left portal veins. It has a direct venous drainage to the IVC. So usually it's spared in diffuse liver diseases. Okay, the importance of it is that it might looks like a pseudomass. For example, you can see here, this is the caudate lobe. It looks like a hypoechoic mass. You should be very careful not to misinterpret it as a mass, because if you change also again, if you change the angle, different maneuvers, you will see that this mass-like thing will disappear. Okay, and you can see it drains here directly into the IVC. It has its own venous drainage, and it takes blood supply from both branches of the portal vein, the right and the left. So, since it works by its own, it's like a separate part of the liver, and usually is not affected in liver disease. When there is when there is disease that damages the liver, this lobe will enlarge to compensatory hypertrophy. So how do we know if the liver, if the caudate lobe is enlarged or not? It's very simple. Just take this measurement. This is the caudate lobe, okay, and this is the right lobe of the liver, okay, and you take this distance and this distance, okay. The caudate over right lobe ratio should, if it is more than 0.65, this indicates caudate hypertrophy. In fact, if it is more than 73%, 0.73, this has a 99% specificity for liver cirrhosis. Okay, and it's easier to measure on CT scan than ultrasound. So be careful to the size of the caudate lobe. It has a 99% specificity for liver cirrhosis if it is more than 0.73. Regarding the hepatic and portal veins, they are the basis of the modern segmental anatomy. It's very important to know the segmental anatomy nowadays, because surgeons are much more capable of going in the liver, of removing focal pathology without damaging the rest of the liver if they know which segment to look for. And that's why we should be very accurate in describing which part of the liver pathology is. For example, the hepatic veins drains peripherally. They are interlobar and intersegmental, and they are used as a dividers. The hepatic veins divide the liver into different parts, while the portal veins, they are centrally. They are within the segment. They feed the segment, okay? They are intralobar, intrasegmental, and they are used to name the segments. So, regarding the anatomic dividers, the hepatic veins, we know they have three hepatic veins: the right, the middle, and the left, okay? The left hepatic veins, the main hepatic vein divides the liver into left lobe and the right lobe, okay? While the right one divides it into anterior and posterior, okay? And the left divides it into medial and lateral. So they are anatomic dividers. The middle hepatic vein divides it into left and right. The right divides it into anterior and posterior, and the left divides it into medial and lateral. Okay? This is the first step in the anatomical localization. Now, the portal veins will define the segments because they feed the segments and they name the segments. You can see here, this is the right portal vein. It's a little bit short. It immediately divides into right posterior and right anterior branches of the right portal vein. Okay? Still with me till now? No one fall asleep? Good. The left portal vein will divide the left lobe into left medial segment and left lateral segment, okay? And this is called the umbilical segment of the left portal vein. It is the only part of the portal vein that is used as a divider. We said the hepatic veins are the dividers, but this small part, it's used as a divider between the left lateral segment and the left medial segment. Okay, so now we have all the anatomy. So the left lobe anatomic dividers into medial and lateral segments. Up, if we are up, we have the left hepatic vein dividing into medial and lateral. If we go down a little bit, we have the umbilical part of the left portal vein dividing into medial and lateral. And if you go down even more, you have the falciform ligament dividing into medial and lateral. So these are anatomical dividers. Now, the portal vein, as we said, it goes in a horizontal pattern, like this. So this site of bifurcation of the portal vein will divide the liver into upper part, superior part, and inferior part. This is in the coronal plane. In the transverse plane, it will divide the liver into anterior part and posterior part. So the same portal vein, it's like a tube. It has a 3D image. It will divide into anterior and posterior, upper and lower, depending on which angle you are looking at the liver, coronally or axially. So combining all of this together, we will have the modern Coinot system, which is a French system for liver segmental anatomy. We have the caudate lobe. As we said, it's an autonomous lobe. It works by its own. This is segment 1. And we have the left posterolateral, that's segment 2. The left anterolateral, segment 3. We have segment 4A, 4B, 5, 6, 7, and 8, according to the anatomic dividers that we said. For example, here in the anteriorly, you have this is the left, the lateral segments, and you have here the medial segments of the left lobe. You have here the right lobe. And if you rotate the liver, you'll see the opposite. So now to combine all things together and see how much we got out of this description, just a very small short quiz. So this is a cyst in the liver. What segment do you think this is? Again, let's go. This is the middle hepatic vein dividing the liver into left and right, okay? And this is the right hepatic vein dividing the liver into anterior and posterior. So this is, and of course this is the umbrella pattern indicating it is superior. So it is in the right anterior superior segment. That is, which segment? Segment 8, exactly. As simple as that. You see the hepatic veins, you know which part of the liver you are. So this is in the right anterior superior segment 8. Excellent. Now we finished the normal anatomy of the liver. Let's come to the Doppler anatomy of the liver. The main portal vein. The main portal vein, the Doppler signal is continuous forward. It's toward the liver. It brings blood to the liver. Has a low velocity averaging from between 15 to 28, 30 cm per second. It's a hepatopedal, as we said. It has an undulating pattern. It goes up and down, just like here. Okay? Up and down, up and down. Okay? It varies with respiration. It varies with, it increases in flow with, on inspiration. It may reflect cardiac variation, sometimes, okay? Slightly turbulent, low rumble flow. It is located between two capillary beds. That's the mesenteric and the hepatic. It brings blood from the mesentery to the liver, okay? So this is the normal portal Doppler flow. It's undulating, it's low velocity, it's variable. Not pulsatile, just undulating, okay? It should not be pulsatile. If you see pulsatile flow, this is abnormal. It may resemble hepatic veins pulsatility. The hepatic veins are pulsatile. We'll talk about it in a minute. So it might look like hepatic vein pulsatility if it is abnormal. It happens in increased right heart pressure. There will be transmission of the pressure through the hepatic sinusoids, for example, in tricuspid regurgitation, also in moderate to severe right heart failure and pericarditis. Again, the golden rule is never say never. It can be pulsatile, but normally. Where does that happen? It happens in a very soft, pliable liver in children. The children have very soft liver that will allow the pulsation of the heart to transmit through the hepatic sinusoids into the portal vein, normally. But in adult, you should not have pulsatility. For example, you can see here, there is pulsatile pattern of the liver, of the hepatic vein, indicating something wrong here, something abnormal. So this is the normal Doppler. What's the abnormal Doppler of the hepatic veins? First, you will lose, when there is a diffuse liver process, will increase the resistance of the liver. For example, hepatic cirrhosis, the most common, okay? First thing will happen, you will lose the undulating pattern. It will be more flattened curve, like this. You can see here, it's flat, okay? You will lose this flattened, the pulsatility. You will have a flattened appearance. It will be continuous, and this is commonly associated with cirrhosis and hepatic fibrosis. Regarding the hepatic artery, what's the normal Doppler? Hepatic artery, it has a rapid systolic acceleration, like that, here, You can see rapid upstroke and continuous forward flow throughout the cardiac cycle. It's always forward. There'll be no down below the baseline flow, okay? It has a low impedance, that means the diastolic pressure is fairly high. It does not reach the baseline, okay? Because it's a low resistance pattern. It has the same direction as the main portal vein. Both of them goes to the liver normally. This is the portal vein and this is the hepatic artery. Okay, both of them the same color, either both of them red, both of them blue, depending on what your machine is settings, but always the same color in normal liver. Okay, the resistive index is between 0.5 to 0.7. That indicates a low resistance pattern. So we can see here the main portal vein and hepatic artery have some sort of mutual understanding. They are friends. When the flow in the portal vein decrease, the hepatic artery will increase its flow. They will supply the liver together. We know that normally the hepatic artery gives about 20 to 30% of the liver blood supply, while the portal vein gives about 70 to 80% of the liver blood supply. This is the basis of the nowadays available catheter liver lesions embolization. We embolize the hepatic artery, close it, because it gives only 20 to 30% of the liver supply. The lesions take blood supply from the hepatic artery, will undergo necrosis, while the liver will stay healthy because it still have about 70 to 80% from its blood supply from the portal vein. So this is very important to know. Whenever there is decrease in the portal vein flow, there is increase in the hepatic artery flow. For example, in this case, the portal vein has a decreased blood flow resulting in increased widened enlarged diameter of the hepatic artery. The abnormal Doppler signal of hepatic artery will show an increased resistance with low diastolic flow. What's happened here? Uh-oh, something wrong. Uh-oh, what happened? Sorry, just little bit. So what happens when the portal vein decreases blood supply? The hepatic artery will increase blood supply, and the abnormal blood flow of the hepatic artery, it will be in when there is increased resistance. That means the diastolic flow will be low. Where we reached? Sorry for this, just computer malfunction. Where we reached? And this is the normal Doppler. So there will be increased resistance. For example, you can see here. This is the hepatic artery, and there is a low diastolic flow. That is a high resistance pattern, indicating increased resistance to blood flow. Okay, this happens in, be careful, can be seen in postprandial. If the patient is eating, this pattern might be seen. Okay, also again seen in portal hypertension, and nowadays we have liver transplant. In transplant rejection, this pattern is common. I've seen a few cases of liver transplantation with transplant rejection, and it's very obvious this high resistance pattern in the hepatic artery. Another abnormal waveform in the hepatic artery, again in liver transplantation, is the tardas parvus waveform. What do you mean by tardas parvus? The systolic upstroke is not fast, it's slow upstroke, just like that, and it goes down also slowly, like here. It's slow upstroke and slow downstroke. This indicates a stenosis at the site of anastomosis of the portal artery. So you do not see the anastomosis itself, you see its effect in the hepatic artery. When you see this tardas parvus, you can be confident that there is an anastomosis at the area of the hepatic artery. the origin, the stem of the hepatic artery. Okay, this is in in liver transplant. It's very important to be noticed. Now, regarding the hepatic veins normal color Doppler, they are towards the IVC and the heart, and they are away from the transducer, and they have a characteristic pulsatile flow. You can see here they are blue, blue, blue because they are away from the probe. Our probe is here, okay, and they are going toward the IVC and towards the liver, and they have a characteristic pattern of systolic, diastolic, atrial kick, systolic, diastolic kick, systolic, diastolic kick, and so on. Okay, so the hepatic veins will also reflect respiratory phases and reflects variations in central venous pressure transmitted from the right atrium. It reflects compliance from liver parenchyma. It has a triphasic waveform, as we said, systolic, diastolic kick. Deep inspiration or valsalva may reduce pulsatility of the waveform in normal patients. Okay, so if with breathing, the pulsatility will be disrupted. Okay, so try to take the portal in the Doppler signal in a suspended breathing, and don't breathe. The abnormal Doppler signal in hepatic veins, what will happen first, there will be non-triphasic flow, and this happens in elevated right heart pressure and decreased pulsatility or amplitude of the phasic oscillation. There is loss of the reversed flow. For example, you can see here there is this characteristic systolic diastolic kick is missed. It's not there. Okay, then it will start to go in a one phase. The kick will be lost, the first, and then more severe cases it will be more flattened. There is something wrong in this hepatic artery. This will happen in a stiff, non-compliant liver. Regarding the sonographic liver patterns, we have the normal liver pattern, we have the centrilobular liver pattern, and we have the fibrofibrotic liver pattern. We cover the normal, now we will cover the centrilobular liver pattern. If you look carefully at this image, you will see it has a lot of portal veins, abnormally a lot. Now the body does not form new portal veins, they are already there, they're just more visible here. Why is that? Because the liver parenchyma is edematous. When you have edema, you have hypoechogenicity. The portal veins will be more obvious. You will see them more clearly due to the edema of the liver parenchyma. Okay, they are increased in brightness and increased in number. But the abnormality is not in the portal veins, it's in the liver. The liver parenchyma is more hypoechoic. Okay, this happens in acute hepatitis, acute right heart failure, leukemia, lymphoma, and toxic shock syndrome, and in about 2% of normal individuals. These 2% are not very difficult to recognize because they have normal liver function tests, they are healthy, everything is okay, but we see this pattern, the starry night appearance. So you can be sure that this is a normal variation, just 2% of population. A very important topic to be careful about here is what's called fulminant hepatic failure. Fulminant hepatic failure represents liver necrosis due to whatever cause. You will see this starry night appearance, which represents acute edema and necrosis. There will be mixed hypoechoic and hyperechoic areas. For example, you can see here, this is a hypoechoic part of the liver with increased portal veins, echogenicity, the starry night appearance. Again, you see here, this indicates fulminant hepatic failure. It is an emergency, okay? For example, you can see in this case, here, there is areas of normal liver, basically normal, okay? While you see some abnormal increased number and size of the portal veins. In the same patient, this was a young male patient, he was healthy تقريبا, but his bilirubin was very high. It eventually reached up to 30, okay? And he ended up with liver transplant due to fulminant hepatic failure. And the story was that he used some herbal medications for bodybuilding and things like that, and it resulted in fulminant hepatic failure in this case. This is another case, again, of fulminant hepatic failure. You can see there is a patchy areas of decreased liver echogenicity with areas of normal liver echogenicity, like this and this. And this was a patient was put on sulfate treatment for UTI, and apparently she was some sort of allergy or toxicity from the sulfur drugs, and resulted in fulminant hepatic failure. Now, the fatty fibrotic pattern, there is increase in the echogenicity of the liver parenchyma. It's exactly the opposite of the starry night. You see no portal veins here. There's no veins with perceptible wall. There's just veins with imperceptible wall. And again, the abnormality is not in the portal vein itself. It's in the liver parenchyma. They are more echogenic. Okay? The echo texture can be smooth or rough, and everyone has its own differential. We will talk about it. It happens. It will reduce the posterior sound transmission. There will be acoustic shadowing posteriorly if it is severe enough. This happens in fatty infiltration, chronic hepatitis, cirrhosis, and acute alcoholic hepatitis. For example, in the echo texture, it can be, as we said, smooth, homogeneous, and this is, of course, diffuse fatty infiltration of the liver. We see it like every day, okay? And it can be rough, heterogeneous, and this is a characteristic of cirrhosis. If it is severe enough, it can cause sound attenuation, acoustic shadowing. Here you cannot even see the liver, whatever you try. It's not because of a mass or calcification, just because the liver is such fatty infiltrated that the beam does not go posteriorly enough, like here and here. Focal fatty liver changes can happen in two ways. Can be focal fatty infiltration or focal fatty sparing. Exactly the opposite. Okay, this is focal fatty infiltration. You can see there are areas here and here and here that are increased echogenicity, and there are areas of normal echogenicity. And exactly the opposite here. This is focal fatty sparing. There is areas of decreased echogenicity. All the liver is fatty infiltrated. The thing is, here you look for mass effect. There is no mass effect. The vessels are in place. Everything looks normal. So this is not a mass. It's just area of focal fatty sparing. Be careful. And it happens in characteristic locations around the vessels, around the gallbladder bed, things around the major structures, not just randomly in the liver. There are some characteristic areas that this happens. Regarding liver cirrhosis, it's a fatty fibrotic pattern, usually associated with a shrunken liver. Not always. It starts with normal liver, might increase in size, and eventually will end up with small sized liver. Very important thing is to look for the surface of the liver. The surface of the liver should be perfectly smooth, flat. If you see any nodularity, micro, macro, doesn't matter. Any nodularity, this indicates possible liver cirrhosis, okay? And again, elevated, the caudate lobe will increase in size with elevated caudate right lobe ratio of more than 73%, has a 99% specificity for cirrhosis, okay? Now, this is an anatomical sample of a cirrhotic liver. You can see the surface is fibrotic, irregular, and you will see with ultrasound is the surface either can be micronodular, the nodules can be bigger, or it can be even macronodular. And with areas of regenerating nodules, you can see some hypoechoic nodules here and there. These are regenerating nodules, okay? The vascular channels will be distorted. Liver cirrhosis accounts for more than 90% of portal hypertension. Here, the guys with the Samsung company have a very nice technology that might help us in diagnosing liver fibrosis and cirrhosis. This is the shear wave technology. It's liver elastography. Just it's a matter that the more solid the liver or tissue, the sound will travel faster in solid organs. So the more solid it is, the sound will be faster. The machine will calculate that and will give you which part of the liver is more solid or more fibrotic, let's say. What happens is that the sound waves will disseminate, like here in this red pattern, and as the sound propagates, and the machine will calculate this speed of sound transmission, okay? What will you do in this elastography, the shear wave elastography? You put the area of interest in certain parts of the liver, it should not be near or in the vessel lumen. It should be in the liver parenchyma itself. And it will give you a measurement in kPa of the liver elasticity, let's say. Okay? So, what the uses of this elastography can be used in chronic viral hepatitis, whatever the cause, fatty infiltration, monitoring drug toxicity, alcoholic liver disease, liver transplantation, and portal hypertension. And there is even a histopathologic correlation with that. You can see that in histopathology, if it's A0, there is no activity, no fibrotic activity, it's given F fibrosis 0, okay? And A1, A2, A3, and so long, so forth, till frank cirrhosis. So you might use this elastography, liver elastography technique to help you detect liver fibrosis at an earlier stage. Regarding portal hypertension, what will happen if there is increased portal fibrosis, increased liver resistance? This will lead to increased portal venous pressure, okay? And eventually the portal venous flow will decrease, and if the resistance is high enough, it will be reversed. Instead of going towards the liver, it will go away from the liver. It will be hepatofugal, not hepatopedal, okay? And when this happens, this is a high prognosis for hemorrhagic changes, because all sorts of collaterals, venous channels will open, and they might result in bleeding. So, what are the findings in portal hypertension? Most commonly, you will find ascites. Ascites is very common in portal hypertension. There will be dilated main portal vein, superior mesenteric vein, and splenic vein and superior mesenteric veins. What do we mean by dilated main portal vein? It's just simple measurement. If it is more than 13 millimeter, it is dilated. The mesenteric and splenic veins, if they are more than 10 millimeter centrally, near the pancreas, before they join, they are dilated. Of course, there will be all sorts of collaterals, splenomegaly, and there will be various Doppler findings. We will talk about them in a while. The collateral veins that you might see are the gastroesophageal. These are the first collaterals to open. The coronary vein, you'll see it from the portal, or the splenic vein going to the stomach. The gastrosplenic, the splenorenal and gastrorenal, here from collaterals from here and here, and you'll see the perisplenic venous collaterals that you normally don't see, intestinal and retroperitoneal collaterals. For example, you can see here, these are different types of venous collaterals in portal hypertension. This is the aorta, and this is the gastroesophageal junction, and you can see these collaterals here, they are gastroesophageal collaterals. You can see here the falciform, the umbilical artery recanalization going to the umbilicus, and you can see here this is the spleen, and at the splenic hilum, all of these of collaterals you don't normally see. Okay, again another case of splenic collaterals. These are possibly gastrosplenic or splenorenal collaterals. Again here between the spleen and the kidney, you can see all these flow voids are present collateral due to portal hypertension. So, the Doppler signal in portal hypertension, you will see the following. First, loss of respiratory variation. It's flat. There is no respiratory variation. There is decreased velocity of the main portal vein. It's below 15 centimeter per second. And if it's reverse flow, it's hepatofugal. It will be away from the liver. And how do we know that? Just put the color flow, and you'll see the hepatic artery in one color and the portal vein in another color. Normally, they both should be the same color, both red, both blue. If one red and one blue, there is reversed portal vein flow. There is severe portal hypertension. Okay, you should not see this hepatic artery red and portal vein blue normally. If they are opposite colors, there is severe portal hypertension, and you can see, of course, enlarged hepatic arteries to compensate for the decreased flow of the portal vein. In portal hypertension, as we said, there is a compensatory increase in the hepatic artery flow, and this will result in what's called double duct sign. You'll see here that in some areas of the liver there are double ducts, two anechoic structures, and usually when this happens, it's due to biliary duct dilatation plus the main, the portal vein in cases of biliary obstruction. However, it can be seen in other conditions like portal hypertension. What will happen here is that you will see the portal artery and the portal vein and the hepatic artery together dilated. If you put Doppler signal, you'll see one blue and one red. There is no biliary dilatation. Classically, double duct sign indicates biliary dilatation, but it's not always the cause. It can be seen also in portal hypertension. Okay, so it can be both. Put Doppler, see if it takes a flow, this is due to portal hypertension. If it doesn't take flow, this is due to biliary dilatation, biliary obstruction for whatever cause. Now, regarding the liver masses, focal liver masses, ultrasound is excellent in detecting focal liver masses. It's specific for cysts more than 1 centimeter, but it's not good in other pathologic entities because we have very few characteristic ultrasound findings. So it's good in detecting, but not good in characterization. We can say there is a mass. What kind of a mass? Not that good. CT and MRIs are much better in this regard. Okay, so it's used for diagnosis, detection, for follow-up, and for ultrasound guidance, for biopsy guidance. Simple cystic lesions, we all see them commonly. It can be, for example, this one and this one. You can see very well defined, very thin wall, excellent posterior sound transmission. It can be cyst on old hematoma, an abscess or a hydatid cyst, can be a bilioma, a serroma. If it is little bit abnormal, not very typical, it can be aneurysm or some fistula like arterioportal or portohepatic venous aneurysms. Multiple cystic lesions can be seen in polycystic, like in adult polycystic kidney disease. You can see multiple liver cysts, and also can be in hydatid. You can see multiple. For example, this is a case of hydatid cyst. You can see multiple cystic lesions. Other types of multiple liver cysts are in choledochal cyst type 4 and type 5. Type 5 is the Caroli's disease, of course. This is a type 4 choledochal cyst. You can see this dilated CPD. And this is type 5. You can see this normal common bile duct with multiple liver cysts. If you look carefully, you'll see they are just a bunch of dilated connected bile ducts. They are not separate cysts. But it's not always easy to distinguish between them. Just a very rapid review of the choledochal cyst. Type 1 is dilated common bile duct. Type 2 has this some sort of diverticulum from the common bile duct. Type 3 has a choledococele bulging into the duodenum. Type 4, like we said, we saw just in the previous slide, has multiple intrahepatic liver cysts with dilated CPD. And type 5 is the Caroli's disease, which is normal CPD with multiple dilated intrahepatic biliary ducts. Complex cystic lesions, there is a lot of types like hemorrhagic cysts, infected cysts, hematoma, abscess, bilioma, serroma, cystic necrotic malignant lesions. It's not easy to differentiate. Ultrasound is bad in differentiating different kinds. For example, this was just a hematoma. Liver abscess can be confusing. If they are smooth, with thick wall, increased peripheral vascularity, they are easy to distinguish. However, if they contain gas bubbles, they might cause some acoustic shadowing and will make it difficult to see the posterior edge of the abscess. Other types of confusion, other cause of confusion, if they are thick enough, they contain thick pus, they will be isoechoic to the liver. You cannot see anything here. However, if you look carefully, you'll see some mass effect on these small vessels, indicating that all of this is an abscess. If you put Doppler, you'll see no flow here. So it can be a little bit tricky. You need to be careful in evaluation. Characteristic feature of cystic liver lesions is the hydatid cyst. Of course, this is a water lily sign. It's very typical, very characteristic. Unfortunately, it's endemic in our area, and we see them a lot of times. Complex cystic lesions can be benign or malignant. This was a hydatid cyst. This was a malignant necrotic metastasis. Difficult to say which is which. it's difficult to distinguish by ultrasound. You can detect, but you cannot diagnose. Okay? Hypoechoic masses in the liver can be benign, can be malignant. We cannot say. It can be abscess, adenoma, focal nodular hyperplasia, hemangioma, microabscesses, even focal fatty sparing, or can be malignant like metastasis, hepatocellular carcinoma, and lymphoma. For example, this case was a focal nodular hyperplasia. You can see hypoechoic, well-defined mass, and that's it. We have nothing else to differentiate which is which. It can be as well a metastasis. We don't know. Some people say that a central scar can be a characteristic of focal nodular hyperplasia. This is true, but it's not diagnostic. Not always every central scar is a focal nodular hyperplasia. For example, this case has a central scar. You can see it here. It's obvious. And it was a focal nodular hyperplasia. But in this case, for example, this is a mass with a characteristic scar, and it was a fibrolamellar hepatocellular carcinoma. So you can never say never. It's not always. Most of the times, but not always. Again, you can see here, this is a giant lesion with a central scar, and it was a giant hemangioma. It's not a focal nodular hyperplasia. Hyperechoic lesion, purely hyperechoic lesion in the liver, most of the times it's hemangioma. But again, not always. It can be a hemangioma or not. For example, this is a hemangioma. It's very well defined. It's hyperechoic. Size usually few centimeters in size. Can be atypical hemangioma also, you can see in the liver. For example, here this hemangioma is hyperechoic but heterogeneous. Here it's isoechoic. Here it's not purely hyperechoic. It has some hypoechoic areas within it. And here has some even cystic areas within it. Okay, all of these are hemangiomas, so it's not always just bright spot on the ultrasound exam. Is every hyperechoic lesion in the liver is a hemangioma? Of course not. For example, this case, which is like typical of a hemangioma, it was a metastasis from thyroid carcinoma. Okay, all of these lesions can appear as a hyperechoic lesion. Unfortunately, we had a case like maybe 1 year ago. He was a young adult, presented with typical hemangioma, about 6-7 centimeters in the liver, with mild subcapsular blood. We thought it was leaking, so he was treated conservatively. He was 32 years old. With the time, he was not improving. He was deteriorating. They even did embolization for the hemangioma, intra-arterial catheter embolization. And again, he was getting worse and worse and worse until someone requested a biopsy for the lesion, although we were suspecting it's a hemangioma. Even by CT scan, triphasic, typical enhancement pattern of hemangioma. And we did a biopsy, and it was a fibrolamellar carcinoma and metastasized, and unfortunately he passed away. So when it's large, when the patient is young, go for biopsy. Even if you are suspecting hemangioma, it can be not hemangioma. Go for a biopsy. Don't be afraid. You might save a life here. So, multiple solid masses in the liver. The differential diagnosis is number 1 metastasis, number 2 metastasis, number 3 metastasis. Other differential diagnosis, it can be metastasis or metastasis. Okay? Then after all of that, you look for other causes. It's metastasis, metastasis, metastasis. You can see here, in this case of cirrhotic liver, you can see the nodular pattern. There are multiple lesions. They are just regenerating nodules here. Okay? Here, it's a lymphoma. Multiple masses here and there. They are isoechoic. They are not metastasis, just it's a lymphoma. Okay? Again, in this case, multiple solid masses. It was a multifocal hepatocellular carcinoma. You can see here and here and here. Multifocal hepatocellular carcinoma. Here, this was an immune-compromised patient presented with multiple microabscesses in the liver. These are just other causes of multiple solid liver masses. But 99% of the times, it is metastasis. Okay? Metastasis can have calcification, of course. Usually, we think of colon carcinoma causing metastasis to the liver, but there is a long list of tumors that cause calcification calcific metastasis in the liver. For example, you can see it in CA ovary, breast, stomach, pancreas, osteo, blah, blah, blah. A lot of different tumors that cause calcific metastasis in the liver. You can see here and here, these are calcific metastasis in the liver. Ultrasound guidance is very nice, very simple, very easy in the liver. You can just put your needle there, take a biopsy, and send for pathology and got done with it. Also, you can put some sort of a catheter to drain a collection, a bilioma, an abscess, whatever it is. You can put a catheter there and almost treat the patient. Just a few words about the complications of liver metastasis. Always when you see liver metastasis, try to look for complications. Is there any biliary obstruction? Because this might need intervention. Is there any vascular invasion? For example, you can see here there is it was a hepatocellular carcinoma invading the portal vein, occluding its portal vein tumoral thrombus. Is there any necrosis, hemorrhage, or infection? For example, you can see here the biliary tree is dilated due to biliary obstruction by liver metastasis. And last but not least is liver interventions using ultrasound. There are a lot of different procedures that you can do to the liver. Number one is the biopsy. We use ultrasound guidance for biopsying different liver lesions all the time. If you have a collection for whatever reason, just by ultrasound, put a catheter there, drain it. A few weeks ago, we had a case, she was like 70 years old and very tired with a large liver abscess. No one accepts to give anesthesia to her. So we just put a catheter there, drain it, and that's it. She's well and she's healthy. Okay? Percutaneous cholecystostomy, I think it is a very underappreciated procedure. It's a very nice, very simple, very life quality improving procedure. You go through the liver, you put a catheter in a gallbladder that is inflamed, and you drain the bile, and the patient markedly improved. But of course, this has in selected cases. For example, I had a case maybe 4 or 5 months ago. He was an elderly with heart failure and acute on chronic cholecystitis. He has multiple gallbladder stones, and in his current condition, anesthesia was risky. So his surgeon just requested a cholecystostomy tube. We put it there for like 10 days, 2 weeks, and we removed it. The acute episode relieved, and he came like maybe 3-4 weeks ago. Remarkable improvement. Even the chronic inflammation is resolved. It's just gallbladder with a few stones in it, and he's very healthy. This is a very underappreciated procedure. Of course, you can do PTC using both fluoroscopy and ultrasound. Catheter embolization is using fluoroscopy. Of course, you don't do catheter embolization using ultrasound. You can inject alcohol into a hydatid cyst to just kill it and leave it there, and many, many other procedures according to the clinical situation. All of this you can do in the liver, some with the use of ultrasound, some with the use of other imaging modalities. And at the end, don't forget to subscribe to our channel. This talk, inshallah, will be available maybe 1 or 2 days. Just write my name and it will be there. And thank you very much for this amazing attendance. And I hope I didn't bore you. Any questions, anything?